Ladies and gentlemen, good evening, good morning, good afternoon, wherever you're joining us from, and thank you for joining us on this very special event. This is the first of its kind on the Teoxane Academy Augmented Reality Seminar. My name is Dr. Ayad Harb. I'm a plastic surgeon from the UK, and I will be hosting the session tonight. I'm coming to you from beautiful Paris, and I'm joined by my colleague and friend, Dr. Cam Lally, who's a cosmetic doctor in the UK, and he's joining us from equally beautiful Birmingham. Tonight's session will be on the periorbital area and the midface. We will be looking at the anatomy and the assessment, and also the treatment techniques for these two highly demanded areas. We'll be using a combination of live patient interaction and an innovative augmented reality format to help us better understand the anatomy and the treatment approach to these areas. So without further ado, let's cross over to my friend, Dr. Cam. Professor Cam, are you hearing me?
Hello, Professor Ayad. How are you doing,
Lovely
my friend?
to see you, Cam, and lovely to see your patient. If you wouldn't mind just introducing your patient to us and running through some of the important anatomy, and we'll focus firstly on the midface, if that's okay.
Yes, of course, and perfect. This is the wonderful Holly who we have. She's a 23-year-old fit and healthy young lady. She has not had any mid-face augmentation before. She's just had a spot of filler in her lips done about a year ago. So otherwise, we have a virgin mid-face and tear trough to talk about. Without further ado, we will look at some of the topographical anatomical markers that will help guide our injections and where to inject, and also, probably more importantly, where not to inject as we look at the danger areas.
Perfect, perfect. So on first impression, what do we see in your patient, Cam? If you wouldn't mind just running us through those first impression, end of the bed test, those visible signs that we perhaps want to target.
Okay, so in a patient generally as young as this, you don't normally see any signs of the aging process or significant bony atrophy or fat atrophy. But with regards to the surface landmarks, you can just about see the tear trough ligament there extending on to form the mid-cheek groove, which is caused by the underlying zygomatic cutaneous ligament. And then the other important area to mark out is the orbicularis retaining ligament just running underneath the orbital rim. And then another important danger zone that we need to be aware of is the infraorbital foramen. And the way we discover that or find out where that is we look at the medial limbal line, or some colleagues may use the mid-pupillary line, and we drop a perpendicular below 1 centimeter beyond the inferior orbital rim, and there we will find our infraorbital foramen. So I can palpate that. Holly, does that feel a little bit uncomfortable just there? Yeah. Yep, so we will mark red for danger there and make sure that we avoid that during our injections.
And that's a deep plane there. It's emerging from the infraorbital foramen, which is, of course, basically at the bone or periosteal level.
Yes, completely correct. One thing that works in our favor is that it is a hooded foramen. So actually, if you are going directly over it, there is a small bony hood which can offer some protection. However, if you have an inferior approach, there is almost an element of a funnel there that will direct whether you're using a cannula, which we wouldn't recommend. We would recommend a cannula, but not a needle in this area, but it will direct it towards the foramen. So that is an area to avoid. The other key areas or anatomical landmarks that we would normally use is, as well as this medial limbal line, which I will just draw on here, and then we have the lateral orbital line. So for me, they are the key anatomical markers that I look at when I'm looking to augment the midface, because this relates directly to the underlying anatomy. So if we look at Holly's face here, I'll just change over. Between our zygomatic cutaneous ligament and our orbital retaining ligament, we have the medial SUF, which is one of the deep fat pads in the face. And this has its medial border with the medial limbal line and the lateral border with the lateral orbital line. As we go beyond the lateral orbital line, we will go into the lateral SUF, which is an elliptical shaped deep fat pad, again sitting on the periosteum, to then discover the third key deep fat pad in this area of the face. We go just below the zygomatic cutaneous ligament, and we will find the deep medial cheek fat pad here. Sometimes there can be confusion as to how lateral it extends, and I will help you with this by drawing on the zygomaticus major muscle, which runs from the cheek apex to the oral commissure, and that is the lateralmost boundary of the deep medial cheek fat pads. So just to recap, we have our medial SUF confined within this space. We have our lateral SUF lateral to that, and then we have the deep medial cheek fat pad sitting inferiorly. We've marked out one of the danger zones, which is the infraorbital foramen, through which we get the neurovascular bundle, that's correct. And then a couple of other key danger areas to be aware of in the midface, and they are to do with the vessels. So we will use red for danger once again. Just along the inferior aspect of the zygoma, we have the transverse facial artery, which is a branch from the superficial temporal artery.
And what plane is that running in, Cam?
So that can vary in plane, but we know that actually with the name, it actually can run superficially. Therefore, you need to be very careful depending on which tool you're using to augment this area, because sometimes we know this, there can be a subzygomatic hollow which can be augmented to give the patient a fresher look. Perfect. And in this area, you could bump into the transverse facial artery as it is running in the superficial planes.
Before we move on to the augmented reality model, Cam, if you just mark on the patient the course of the main blood vessels in the face, the facial and angular arteries, and of course the facial vein. And if you could just give us a rough guide about the superficial fat pads to finish.
Yes. So we have the facial artery that is coming into the face as a branch of the external carotid, and it will cross along the anterior border of the masseter, and it will course medially, and it will give off the superior and inferior labial branches, and then it will traverse just lateral to the nasolabial fold and along the aspect of the nose towards the medial canthus. We have a shift in plane from deep to superficial around about the level of the GK points of the lips here. So therefore, when we inject, we must be careful with regards to what plane we're in, as it is becoming superficial. And then with regards to the facial vein usually traverses and splits the face in half, and it is usually found within the zygomatic cutaneous ligament, and it will cross this way. Remember, these are general anatomical plans here, but there can be significant variation. Sometimes the facial artery can run duplex with the facial vein, so please be aware when you're injecting and stay vigilant.
Perfect. And the superficial fat pads to finish, just in terms of where they are on the patient.
So the superficial fat pads of note here that we will augment are the medial superficial cheek fat pad and the middle superficial cheek fat pad. We may put a little bit in the lateral superficial fat pad, but the two fat pads that are sitting superficially that we would like to avoid are the nasolabial fat pad, which, as we know with age, can hypertrophy or appear toast, which will then create the fold. And then this infraorbital fat pad here, which we also know appears to hypertrophy with age, but also contains a delicate lymphatic system that, if disrupted, can cause the dreaded malar edema.
Okay, that's perfect. Thank you for that concise run through of the anatomy. We're going to move on to an augmented reality model of exactly what Cam was describing there, so that we can see in more detail what's happening under the skin. And we move on to a subject that's very close to my heart, that is the fat pads of the face. The fat pads of the face are vital to know, and to know them intimately. They are generally organized in two layers, the superficial layer and a deep layer. And each layer is then organized into compartments. So we'll strip away the skin here, and we can see the superficial fat pads of the face. In youth, in young age, this is a nice confluent, blended surface of fat pads that are well connected to each other, blend seamlessly into each other without gaps or hollows. And they, of course, as Dr. Cam was describing, they are organized into specific pockets divided by septa. Now, the important thing about those divisions is that this allows us to target certain fat compartments and leave alone other fat compartments. And when we target those compartments with the filler of choice, the filler will stay within that compartment, contained within those septal divisions and those boundaries that are set anatomically. So the typical areas that we like to avoid, the nasolabial fat and the infraorbital fat, the malar fat, this is relative to the midface. Of course, then we have the superficial jowl fat, which also misbehaves in older age, and it becomes more hypertrophic and ptotic, so bigger and heavier. Whereas other fat compartments in the face, such as the superficial cheek compartments, the medial, middle, and lateral, these generally become atrophic, smaller, thinner. And so there we see the difference starting to emerge, where we have adjacent fat compartments becoming one bigger and one smaller. And therein lies a problem, because that starts to develop shadows and contour irregularities in the face that are very characteristic of the aging or deteriorating face. Now let's strip away the superficial fat. What do we have beneath that is the SMAS layer of the face, which contains all of the superficial mimetic muscles of the face, the muscles of facial expression. In the midface, primarily, we have the orbicularis oculi muscle, we have the zygomaticus muscles, and the perioral muscles, all intricately related to each other and all impacting on each other's function. Within this layer, it's really important to remember that within this layer lies the vascular anatomy, the facial artery and the vein that will weave in and out through the SMAS layer. Now let's move away from the SMAS layer and go deep to it. And here we have the deep fat compartments, those fat compartments that Cam was describing earlier. These fat compartments, just like the superficial fat compartments, are contained within well-circumscribed fascial boundaries that will hold them in place. Now, the difference with the deep fat compartments, unlike the superficial fat compartments, is that they all atrophy and they all deflate with age and with significant weight loss. So what happens is the face will start to lose its projection and its support. And so we start to develop, again, those very distinctive and characteristic signs of aging. And again, we go back to the principle of targeted treatments. The wonderful thing about the deep fat pads is that they are well contained within these pockets, within these balloons. And so if we can identify the anatomy and we can inject directly into those fat compartments, we're able to replenish natural volume, and that will recreate the natural function of the deep fat pads, which is support and lift. And it will also, more importantly, avoid any superfluous treatments that may either be a wasted treatment or, more importantly, may expose the patient to undue risk. And then finally, under these deep fat compartments, of course, we have the periosteal layer, which is the bony layer, the bony framework and support to the face. Now, as Cam alluded to earlier, there are danger zones that we must appreciate within the face. Generally, a line level with the mouth. Beneath this line, the danger is deep, and so we try and stay superficial. And above this line, the danger is superficial, where the artery and the vein are generally expected to lie. And so we try and target our treatment deep. But of course, as with anatomy, as we expect with anatomy, nothing quite ever follows the rule, and there are always exceptions. And here, the one curveball that we must always be aware of is the infraorbital artery, which is a deep, very deep artery lying on the bone. So whilst we say deep injections are relatively safe in the midface, be aware in the midpupillary or medial to the midpupillary line, that is a danger zone as well in the deep and the superficial planes. Now we're going to move back to Cam, and we're going to start to assess the patient and plan our treatment relative to the fat pads, and also talk about product choice. Back to you, Cam.
Thank you for that. Thank you, Ayad. That was a really, really good augmented reality presentation and made the anatomical layers very, very clear. So back to wonderful Holly. We need to make a plan for this young lady. And when we had a little discussion beforehand, she had specific requests with regards to making her cheekbones a little bit more contoured. That was literally her sole request for the mid-face. And then I put my thinking hat on and just thought I'd do an assessment and see what I could improve to improve the overall aesthetic. We have to bear in mind she's 23 years old, so she's very young and she has a pretty face. And if we look aesthetically at the overall shape of the face, she has a heart-shaped face, which is again the ideal feminine aesthetic. She has got quite good curves and transition zones when going from one area of the face to another. So the curvy linear features are feminine. And all we need to do is just enhance. So this is more of an enhancement and beautification process rather than a true restoration or rejuvenation, because the changes associated with aging that Ayad was hinting at with regards to the anatomy, we have not really yet started to see them here. Therefore, we will assess Holly's face and just see what we could do to help improve and augment it. One thing that you may be able to see from a global perspective is that her left side, so on this side of the face, it generally sits slightly higher than her right side. So that starts from the position of the brow, the position of the lid, the extent of the zygomatic arch and the position of it, the alar margin, even the corner of the mouth, okay? So all of that side is slightly higher than the right side. And this is normal, and it's important to reassure your patients that this is normal. The two sides of the face are siblings, not twins, just like the brows themselves.
Perfect.
Okay.
I mean, that's a really important distinction there, Cam. It's a young patient, and these differences between left and right are totally normal and not necessarily related to any aging or any progressive process that's going on. This is a genetic difference, a developmental difference between left and right, which is completely expected and normal. And it probably originates from all levels of the face, from the bone all the way up to the skin.
Wonderful. Yes. Thank you, Ayad. So just now looking at Holly's particular anatomy, I just want you to tilt your chin down a little bit, please, Holly, and look straight ahead. Okay, and can you give us a smile, please? So we will always do dynamic assessment as well as static, and then we will look at Holly's face in different uh, directions. So you can see there is good cheek volume on smiling. So that is a sign of youth. Relax for us, please, Holly, and smile again.
And relate that to the
Okay, but
anatomy cam. What is that that's producing that volume in that area?
okay, so we know predominantly the volumization that is caused here will be due to the movement of the superficial cheek fat pads, okay? However, we do know there is this structure called the transverse facial septum that can actually augment the deep fat pads to help just buffer the superficial fat pads, but the majority of this is caused by the superficial fat, and therefore we must respect that when we are helping rejuvenate the tissue itself. And one little thing I'd like to highlight is the difference in the light reflex in the cheeks, just reiterating the fact that this cheek is sitting a little bit higher. So we never promise we will correct asymmetry, but we can help just soften the difference. So that's one thing that we will look at. And then what I will get Holly to do is just turn her face to the side, where I think the difference is a little bit more pronounced. So head back a little bit. Okay, so what I'm trying to show here is having Holly with the Frankfurt plane, which runs from the tragus to the inferior orbital rim, you'll be able to see her cheek position relative to the most anteriorly projected part of the cornea. Holly, if you just move back a little bit for me, thank you. And we refer to this as a negative or a neutral to negative vector. Close your eyes, please, Holly. So if I pop this Q-tip on the cornea, you can see that actually it needs to angle backwards as it goes over the most anteriorly projected part of the cheek and look straight ahead for us. So that tells us that actually she has an element of maxillary hypoplasia, which, as Ayad alluded to earlier, is developmental. It's a normal variant for Holly. There's nothing wrong with it, okay? However, we know that when we're augmenting the midface and the tear trough area, if we do have this neutral or negative vector, we will improve the overall aesthetic by augmenting the midface first to help support the tear trough region above it.
Perfect.
Sorry, Ed, were you going to say something?
And because this is originating, as we said earlier, originating from all layers, it's going to be a multi-layer approach. So we're always assessing the patient anatomically, always relating the clinical signs that we see to the underlying anatomy under the skin.
Perfect. So that leads me nicely to the next part of my plan. So we've covered the anatomy, we've covered our A, and if you have been following Tioxan and Tioxan Academy, there are three core pillars when we approach a patient's treatment plan. They are anatomy with assessment and the aging process, and then we have T for technique, and then we will finish off with the product. So we'll now discuss the technique that I will use to augment the anatomical areas discussed, and then, of course, the products that are most appropriate for the regions. So to augment the deep fat pads, which I marked out earlier, I will use a needle down to the periosteum, which I know will take me into the deep fat pads. Okay, I will augment the medial souph, and I will augment the lateral souph, and also the deep medial cheek fat pad. I will use those anatomical markings that we marked out earlier to guide my injections, and that will help rejuvenate the deep fat pads. Thereafter, I will use the multi-layering technique, informally known as the sandwich technique, because you're putting in 2 layers. And I will augment the superficial cheek fat pads, namely the medial and the middle cheek fat pad, using a cannula, because I will be traversing the superficial layers. And we know, as I had said earlier, that the danger zones and the vessels can traverse the superficial tissues in this area. Therefore, using a blunt-tipped cannula will help us mitigate the risk. It does not eliminate the risk, because a thin metal pipe can still penetrate a vessel wall, but it helps offset the risk. And I will use a fanning technique to then augment those cheek fat pads. So onto the product choice. And for this, I think it's important to assess the soft tissue envelope and just see how much there is for you to play with. And also the skin quality. In a 23-year-old, you would expect good skin quality, and you would expect a good tissue envelope unless they are particularly slim or they are particularly active and they have burned away their facial fat pads. So in this case, we can use ultra deep onto the periosteal layer to augment the deep fat pads. We're using a projecting high G prime product which is 10% cross-linked and has a concentration of hyaluronic acid of 25 milligrams per mil, which will really give us or replace that hypoplastic maxilla that is, genetic and a normal variant for Holly. Then we will use a dynamic filler. We will go to the RHA portfolio, the resilient hyaluronic acid portfolio, and I will use RHA4 and I will fan that into the superficial fat pads using a cannula. So RHA4 has got 23 milligrams per mil of hyaluronic acid, and it's capped at 4% cross-linking with those longer dynamic mobile chains of hyaluronic acid, which will respect the dynamic movement of the superficial fat.
That's fantastic. And will you be treating the face differentially, left and right, considering that there is a little bit of a difference in the symmetry?
That's a very good question. So I will treat the right side of the face with the aim of trying to just elevate the zygoma to the same position as the left. Again, you never promise that you will be able to do that exactly, but you can attempt to do that. And the way I will attempt to do that is by using a small amount more volume compared to the left side and slightly augmenting my injection sites. The other danger area, one thing that we sort of forgot to mention, was the zygomaticofacial foramina that can exist around the position of where the lateral souph is. And again, these come out from the bone, and there can be multiple locations of them. And the only thing when using a needle on the periosteal layer is vigilance here to ensure that an adverse event hasn't happened. You could bypass an element of that risk using a cannula deep and superficially, depending on your technique of choice.
Perfect, perfect. Thank you, Cam, for that comprehensive assessment. I'm going to show you a very interesting video next, or a model. Again, a different model to what we had before. This is a three-dimensional model of a face, and I'm going to demonstrate to you the structure, the layers of the soft tissue envelope of the face. So here, in a very basic diagram, we can see that the bone at the base, then we have the deep fat, the superficial, the SMAS, the superficial fat, and the skin. But we've talked about the location and the structure of the soft tissue layers. What's now more important, and now we can start to consider the role, the function of these layers, especially when we're talking about the fat, the role and the function, and also the behavior of these layers when it comes to movement, which is really important, of course, in the face. The face is not a static object. It is constantly moving, and it's really important to appreciate, recognize, and respect that movement and those properties when we're adding products into the face. So let's move on to our live model. I'm going to show you a very, very interesting model, a cadaveric dissection, what we call the smiling cadaver. So this model is really going to demonstrate the movement of the face. We are mimicking a smile here. And you can see very nicely a really good demonstration of the bunching and lifting and projection of the midface when the patient smiles. And then when we look at a cross-section across the lateral aspect of the anterior midface, we can see those layers organized from the superficial fat, then we have the SMAS, and then the deep fat, the souph, and the other fat compartments. And you can see when the patient is moving, you can see that the superficial fat, which lies above the muscle, is affected by the muscle movement. So when the muscle will contract and lift with a smile, so the fat will lift with it. And with that comes those beautiful apples in the cheeks that rise up and give the face its very distinctive and very beautiful and attractive projection and volume. And then when the muscle is relaxed, that fat slides back to its natural position. And you can see very clearly how that fat slides over the zygoma. It slides over the zygoma with the muscle. But what's also really important to see, if you look under the muscle, you'll see the deep fat, and that's staying absolutely in place. It's solid, it's anchorage, it's support and structure more than it is to do with movement. So here is the distinction between the deep and the superficial layers in terms of behavior and role. The superficial layers are there for padding, are there for volume, are there for movement. And so with that, with treatment, we must respect those properties and use a product that is suitable and will allow some of that movement and some of that natural behavior to continue without looking solid or interrupting that natural function of the fat. And so that's why we prefer to use a resilient hyaluronic acid, this new generation of hyaluronic acids that have that property of flexing and moving and stretch and return to their original shape. In the deep fat, well, you can see in that cross-section, you can see the deep fat is absolutely solid. It's there for support and anchorage and helping to provide the tension for the muscle above it. Its role is not movement. And so, again, we choose a product that is appropriate for that layer. And so we choose a product that's going to mimic and copy and support that layer's function, and that function is volume and projection and support and anchorage. And so for that's why we choose a really strong, cohesive, solid, long-lasting filler like Ultra Deep for the mid-face. So that combination of Ultra Deep deeply and RHA4 more superficially is a perfect combination that will mimic natural function without interfering with those natural expressions and the natural function of the fat pads of the face. Now we're going to move on to the most interesting part, of course, of this presentation, and that's the live planning and the live treatment by Dr. Lally. So back we go to Birmingham.
Thank you for that. Very, very interesting looking at the smiling cadavers. I think it put Holly off a little bit, so we had to cover her eyes for that, but she's back with us now. So just a recap with regards to the plan and the order of treatment. So just recapping the ATP before we start the treatment again. So anatomically, we're going to augment the medial SUF, and one thing that Professor Ayad and I are assuming is we all know what SUF stands for. So SUF actually stands for suborbicularis oculi fat, okay? We just make that into SUF because it's a lot shorter, but that's what the SUF stands for, just to clarify. So we'll augment the medial SUF, and I will use a needle to the periosteum, and I will be using Ultra Deep, which we know is a projecting, strong product, okay? Then we will move to the lateral SUF, the elliptical deep fat pad, and I will augment that. And in a feminine face, I normally do a couple of injections to respect the natural taper of the zygoma, okay? However, always keeping in mind that we have a 2-to-1 volume ratio in a feminine face when it comes to anterior to lateral zygoma, respectively. And then the final deep fat pad injection will be into the DMC, or the deep medial cheek fat, and that will be again with a needle onto the periosteum. And we will be using Ultra Deep for that. And then to finish off with the multi-layering technique, where we're augmenting the superficial cheek fat pads, namely the medial and the middle, we'll be using a 25 gauge 50 millimeter cannula and RHA4, our dynamic volumizer. Yes, you heard that right. It's a volumizer that is dynamic. It's not rigid. It moves with the tissues. It respects the forces applied, and it doesn't kick back. It's not stubborn. It moves and flows as the tissue that's placed in does so. So without further ado, I will start the actual treatment.
In which order will you treat the fat pads, Cam? Will you start with the
So
deep?
I will start with the deep. Yes, I will start with the deep because just like the aging process happens, and we know that the deep fat pads atrophy and the bone is resorbed, what I refer to as the table being immobile. I want to restore the structure of the table before I spread out the tablecloth, as it were. And the tablecloth is in reference to the mobile layers of the face, and namely in Holly, which will be the superficial cheek fat pads.
Perfect.
So just a final clean before. And we have ultra deep here, which comes as a 1.2 mil syringe. So you get 20% extra compared to your average syringe. And you'll note that the stock needle is a 25 gauge, 25 millimeter needle. So it's a 1 inch long needle compared to the stock needle that you would get with the RHA range, which is 27 gauge, and it is 13 millimeters in length, so half. Okay, so if you do not feel comfortable using the stock needle, you can always switch across to the 27 gauge needle. So let's do the first injection. Just turn your face slightly towards me. If you look up, please. So remember the anatomical boundaries, the medial limbal line, and then that is where the infraorbital foramen is. So we will be lateral to that. And because I'm going deep, I can lift up the superficial tissues. Small scratch coming up. And we are on the bone. If I was not on the bone, I would not be able to rest the needle there. And then I will just gently squeeze out a small amount of product here. So I'm aiming for around about 0.1 to 0.15, because we know from surface volume coefficient studies, again done by the Cotofana group, that whatever you put in here, pretty much all of it will show on the surface. Okay, so we can see that projected. It's projected as a small little bead, and what I will do after I've finished the other injections will be just to gently press it down, and it will become part of Holly's maxilla. Okay, just turn slightly to the side.
You can see
and
that
then
as an
now,
instant correction there, Cam. You can just see how the light has just corrected
changed.
itself and is much more symmetrical with the other side, actually. You've got a lot more anterior projection with a very small volume.
Yes, so just to show that it's not smoke and mirrors, we have only used 0.1 of a mil so far. Okay,
Perfect.
So I'll get on with the next injection, which will be lateral to that lateral orbital line into this elliptical fat pad, which is known as a lateral SUF. Again, I will lift up the tissues, small scratch. There we are. And I'm on bone, otherwise I wouldn't be able to rest my needle on it. And usually I do a matching bolus in this first injection in the lateral SUF. And after we've done this, I will do one more injection laterally to just taper along the zygoma. Perfect. So we have 2 injections there. And then I'm going to do one just next to it.
That's
and
great.
That will
So
help
this is
with
an anatomical, directed, and very specific injections, isn't it? You're really targeting those fat pads. You're not really going by any measurements necessarily or by any templates. You're going anatomically, which is, I think, the most consistent and reliable way to do it.
I agree. This is translatable to any ethnicity and any gender of patient. Obviously, you would respect the characteristics of masculine versus feminine, but essentially the underlying anatomy is translatable. Hence, it's a universal approach. So a small injection, just lateral. Well done. And I will use just half of the volume that we used already. So that was 0.05. Perfect. How are we doing so far, Holly? You okay?
Yeah.
Perfect. And now if you just rest your face straight back, Now I'm aiming for the DMC, the deep medial cheek fat pad. We know that exists below the zygomatic cutaneous ligament and is laterally bounded by zygomaticus major from the oral commissure to the apex of the cheek. And because of the curvature of the zygoma, I go in at a slight angle to ensure that I hit the surface correctly and I don't overshoot the surface compared to going directly at 90 degrees. So just beneath the zygomatic cutaneous ligament, little scratch, we're in, and there I am on bone, and I'm in the DMC. So here, the DMC can take a lot more volume compared to the SUF, and from the same surface volume coefficient studies, it was shown that when approximately 1 mil of product was put in, around 25 to 30% of that was visible on the surface. So I am putting a little bit more in here. I'm aiming for a 0.2 in here, which is still relatively conservative.
So in total, for the deep fat rejuvenation, you're going to use less than half a syringe, would you say?
Yes, literally less than half a syringe. And that's what I wanted to show you, is that one full syringe will treat both sides here. And the kind thing to do when going from one side to the other is to obviously change the needle. The eagle-eyed of you will have noted that I used 4 supraperiosteal contacts on that side. And we know from the evidence that 3 usually will end up blunting a standard 27 gauge needle. But without even augmenting the superficial fat pads, I will let you all have a little look at what we've done so far.
So it looks absolutely fantastic. Very,
Perfect.
very effective treatment with minimal volume, and you really can see the difference. It's very, very good indeed.
And just at that view, you can see a restoration of the OG curve, which had flattened actually on this side, and that's what augmenting the lateral SUF can do. So just turning Holly this way. So now what we will do is augment the superficial fat pads that are overlying the deep fat. And as I said earlier, I will be using RHA4 for this process. And I'll be using a cannula. So RHA4, which should be coming into your screen now. You've got the colored syringe there, the colored plunger, and it also comes as a 1.2 mil syringe. And attached to that, we have my 25 gauge 50 mil length cannula. And sometimes I get asked, why do I use a 50 mil cannula? Because actually it gives me excellent reach, okay? And when we're augmenting the superficial fat pads, we want to avoid this nasolabial fat pad, which in a younger patient allows me to start slightly higher up the zygoma and just create that beautiful curve. The other thing about this cannula is it's got a little bit of flex in it. A shorter cannula often can be quite rigid, and you may find that there's not as much give to respect the curvature of the zygoma. So just remeasuring here, just to see where I can reach. And a lot of people will mark the skin. I like to just use a fingernail to apply a bit of pressure onto the area that I'm going to inject, and it will usually stay there for 90 seconds to 2 minutes. And again, the most eagle-eyed of you will see that there's an entry port there from the 25 gauge needle that I use with Ultra Deep. I am going to try doing this and putting the 25 gauge cannula through that entry port that already exists. I will just give the skin another little clean.
So you're now going to aim purely, you're done with the deep fat pads. You are now moving away using a completely different plane, different technique, and different product.
Yes, that's correct.
Perfect.
That's correct.
Right, so
great
this
summary.
Is a great demonstration of just a systematic approach to these treatments. Rather than filling randomly in the face, this is very targeted and it's very specific, anatomical. There's very minimal wastage of product and maximum effect with a tiny volume.
That's it. And thankfully, we have been able to use that 25 gauge entry port that we use to augment the deep lateral SUF, and I've been able to go in and get my cannula into the superficial layers. So you should just be able to see the outline of my cannula. I'm not injecting anything here. I'm just trying to show you where the position of the cannula is. You should be able to just see the outline of
we can
the
see it
soft
clearly on
tissues
the camera.
around that cannula.
Yeah, we can see that clearly.
Okay, excellent.
Very good.
So Applying a bit of counter traction is always helpful to get the cannula to glide through some of those retinacular cutis and the septa between the two fat pads that we're traversing here, the medial and the middle. And now I'm just applying a small amount of pressure and just augmenting the areas with a retrograde linear fashion. Comfort-wise, how are we doing, Holly? Okay, excellent.
Now, of course, all of these products do contain lidocaine. So really, the only element of this that is felt by the patient is that that entry port for the cannula. Otherwise, it should be a completely comfortable and virtually painless treatment.
That's correct. That's right. So I've used 0.4 mils so far, and I think that's given Holly quite a healthy anterior cheek, which is blending nicely to the zygoma. So what do we do now? In a younger patient who is after beautification, what we can do is actually go in the reverse direction and just continue augmenting the lateral aspect of the zygoma. So I will try to do this without getting the cannula to exit the skin. And remember, you need to stay in the correct plane here. If you find a lot of resistance when you turn around the other way, it usually means you have snagged the SMAS layer, which in this case will be orbicularis oculi. The patient will find that uncomfortable and painful. Look at those signs and pull your cannula out a little bit more, and then you will feel a little release and you will be able to glide into the correct layer. So now we are going more towards the lateral superficial cheek fat, and again, hopefully you can see the depth of my cannula, that it's not deep, it's literally sitting in the superficial layers, and I will just do a very subtle augmentation. The main reason I like to augment this area is because if you follow the tail of the brow down, you will find the suture point between the zygomatic bone and the temporal bone. And with the aging process, that can leave a little dip, a little step in the zygoma. But we can just beautifully and safely augment this. And we are almost there. And you're probably thinking, how much product is he used? So I will reveal that in literally a few seconds. But Holly, are we comfortable? Yeah. Okay, beautiful. So now I'm just going to pull that cannula out in the same direction I went in, which was 90 degrees. And we have used 0.5 mils, okay? We have just used 0.5 mils, and I will let you have a little look at Holly's midface.
Okay, that's fantastic. So that's a total of 1 ml used between deep and superficial.
Yeah, and Holly, if you could just give us a smile.
Very good.
Perfect. No golf ball cheeks, no chipmunk cheeks here. We've respected the anatomy, and we have put a dynamic product in the dynamic layer. Give us a nice big cheesy grin. Look at that. Beautifully natural, okay? It doesn't actually impede the orbital rim. It doesn't make her eyes look smaller and relax for us. And in fact, it's made her look more youthful and rejuvenated. And now the side that was sitting higher could do with a bit of a TLC from us and get it to match the side that we've just augmented.
Okay, that's absolutely fantastic. Thank you very much for that wonderful demonstration. You've used such little product, and you've got exactly the effect that the patient's face needed. I don't think there's much more to say about that, actually. What I do want to show, if we can move back onto the augmented reality screen, I want to show you where Cam was and what he was doing with the tip of his cannula, where that was lying relative to the fat pads and relative to the layers in the skin. So if we can move now onto the augmented reality model, back to our model where we can see the layers of the face, and let's start with the deeper layer. When we're ready, we'll bring up the model and we should be able to see. Here we go. Right. So so Cam used a needle, perfectly legitimate, perfectly safe in the right hands. Some people prefer a cannula. Personally, I use a cannula, but it's the same treatment. If you know the anatomy, then you can target the treatment appropriately. So what he's done is he's localized those deep fat compartments according to those landmarks, and he's entered from a safe entry point. He's injected targeted filler deep onto the periosteum. and that should replenish the volume within the deep fat pads, but also help to help support the function of the bone as bone structure itself. So those deep layers are supported by the ultra deep that's injected in very small volumes at the level of the bone. And when that treatment is done in the right way, what you'll find is that the fat pads will do exactly what they were designed to do. They will project in the right way. They will support in the right way. And you'll find that the anterior midface, the upper part of the anterior midface is lifted up towards the eye and gives it this very nice forward projection, and it corrects that vector difference. And also it helps to support the tear trough above and lift out the nasolabial fold inferior to it. The same with the lateral SUF. When Cam injected into the lateral SUF, that was a periosteal injection that localized and targeted the lateral SUF, which is a deep fat compartment. And when that is targeted, again, the function, the role of that fat compartment is replicated in a very natural way. And the role of that fat compartment is to give lateral projection to the anterior midface, and also give support to the lateral canthus of the eye. Wonderful. Nothing artificial going on, because we are replicating the natural fat compartments and the natural soft tissue layers. And what that translates into always is very natural, completely individual results. No result is ever the same, because no patient's anatomy is ever the same. So all you're doing is replenishing the patient's natural anatomy and taking them back to their optimal, personal, optimal shape. And then Cam went and targeted the superficial fat pads. So in order to target the superficial fat pads, the cannula was flatter, more parallel with the skin, running immediately under the level of the dermis into that superficial fat soft tissue. It's important to avoid those areas of superficial fat that are problematic, like the malar fat. No one ever asks for more malar bags, and no patient ever requested heavier nasolabial folds. So we avoid these areas altogether. We target the areas, one, that are needed, so those areas that naturally age and deflate, like the medial and the middle superficial cheek fat, and we can just target the anatomical landmarks, drop a small amount of appropriate dynamic filler into those areas, and what again you'll find is that they will act exactly the way they were designed to act. So immediately they give this lovely confluence and smoothness to the surface of the skin, because now the fat compartments are blended in well. They all match and they all join each other in a flush and smooth way. The other thing that you can do when approaching the superficial fat is to look for those asymmetries or those hollows that result from treatment. For example, when we create a nice sharp zygoma or a nice sharp lateral cheek, it looks fantastic, but it can leave behind it certain iatrogenic hollows, such as here in the preauricular or the submalar area, or up here in the temple. So again, we can target the superficial fat here in a very gentle and very targeted way, drop a little bit of, again, very smooth, resilient hyaluronic acid, RHA4 or RHA3, target that to blend into those areas and just produce these very natural contours without any harsh lines or shadows. So we have looked at the anatomy. We've talked about the danger zones within the face and the midface specifically. We've then talked about a patient assessment, looking at the priorities, the first impressions when you look at a patient, you think about the priorities for this patient's face: shadows, asymmetries, differences, collapse, vectors, all of these things that really jump out at you. If you notice them first, they will be the things that you should target first. And then we went on to talk about the dynamic properties of the different layers of the face and the different fat pads of the face. Really, really important to know about, but also to help to maximize, use that to your advantage so that you can produce very natural looking results every time. And then finally, of course, Cam demonstrated very, very elegantly a subtle but very effective rejuvenation of the mid-face to produce better symmetry. So the left and right matched, that natural asymmetry was diminished, and to give the patient a beautiful beautification without any exaggeration to any of her natural features. So that concludes our mid-face section. We're now going to move on to the tear trough. The tear trough is the cousin of the mid-face. It's the next door neighbor, okay? But it's vital that we approach the mid-face before we move on to the tear trough. And so Cam, if you could again talk to us about the anatomy, the relevant anatomy, landmarks, and danger zones in this very critical area.
It would be my pleasure. Thank you for those wonderful tips and tricks, actually, in your session. So we are back with Holly. As you can see, the augmented cheek is sitting there nice and proudly. And this is the side that we haven't augmented. And the importance here is to see the impact that the mid-face rejuvenation, especially anteriorly, has had directly or indirectly, as we should say, on the tear trough. So, Holly, I'd like you to just tilt your chin forward, please, whilst looking at the camera the whole time. So here I'm trying to exaggerate the hollow that we associate with the tear trough on both sides, but you can quite clearly see the side that's augmented, the tear trough is not so nearly pronounced as on the side that we haven't augmented yet. And Holly's tear troughs were a bit of a bugbear for her. She said it was one of the areas that she didn't like because it made her look tired and her makeup sat in those hollows. Looking at Holly's tear troughs, so looking at the anatomy a little bit more closely, we can see that in reality, she only has a hollowing extending to around the mid-pupillary line, which the purists would say this is a true tear trough, okay? Because any extension beyond the mid-pupillary line and going laterally is now the palpebro-malar groove between the lid and the cheek. And Holly doesn't really have one to talk about. And just looking at the non-augmented side, you can see that the true tear trough there is a little bit more exaggerated. Anything that you'd like to comment on about that, Ayad? Are you happy for me to proceed?
I think it's exactly like you said. You can see the effect of the mid-face on the tear trough. It's a secondary effect, but it's very visible in this patient. That's why it's really important, if you have a patient with a tear trough concern, address the mid-face if it's needed, because very often you find actually they don't need much in the tear trough. Whereas if you do the opposite order and you go straight for the tear trough, you're more likely to need more volume, and more volume in the tear trough could result in problems.
I completely agree. I completely agree. I think both of our philosophies of less is more, are very true here, and we are very much aligned, trying to maintain natural, normal features rather than over-exaggerating them. And so just wrapping up the assessment of the tear trough before we have a talk about the key danger zones in this area. The other thing that's important to look at here is any elements of pigmentation. So often patients will come to you with a problem of dark circles, the bane of our life, dark circles. And sometimes that can be due to the shadowing associated with the tear trough, but a lot of the times it is due to pigmentation. And it can be actual pigmentation within the skin, or as in Holly's case, we can see on stretching the skin is actually the translucency of the skin, which then gives rise to the appearance, that violaceous appearance of the orbicularis oculi muscle. So here we can see the muscle because of the thinness and the translucency of the skin. Also of note, medially in the tear trough, we do not have any fat pads. So the traditional 5-layer structure of the face that we so often follow with skin, subcutaneous fat, the SMAS layer, deep fat, and bone does not apply for the majority of patients. There are very, very small exceptions of certain ethnicities that can have a small fat compartment there, but the vast majority of the patients that you will treat will have no fat here. They just have the 3-layer structure of the face. Skin, SMAS layer, which in this case is orbicularis oculi, and that is fused very tightly to the underlying layer of the bone or the periosteum. So when we are augmenting the medial trough, often you will find yourself or your cannula getting lost amongst the fibers of orbicularis oculi that are fused very tightly to the underlying periosteum. And laterally to this medial limbal or midpupillary line, you will have your 5-layer structure of the face again.
Perfect.
So,
Cam, if you wouldn't mind
yeah.
just guiding us through the landmarks that you use to guide your treatment, where to start and where to stop, and also relate that just to the underlying, some of the vascular structures that are in the area.
Okay, so onto the danger zones. One thing before I forget, when you assess the tear trough area is to look at the skin quality. So I will do a snap test, which is commonly accepted to assess the skin quality with Holly, 23-year-old. You would expect it to snap back instantly, as it does. In an older patient who's got elastosis, potentially due to sun damage, then you will need to think twice about using any product in that area because it could worsen the under eye area. So back to looking at the anatomy and the vascular dangers. So we have in the medial limbal line, a centimeter below the orbital rim, in this little indentation here, the infraorbital foramen, okay? We need to avoid this. Our cannula needs to glide along the periosteal layer, but above where the foramen is. Like I mentioned earlier, thankfully it is a hooded foramen, so for you to actually truly cannulate it will depend on your approach. So that goes on to Ayad's second question is, what would my approach be? So I use my 50 millimeter long cannula, and I have a lateral approach to try to avoid the danger in this area, the infraorbital foramen, but also we need to be aware of the danger zones more medially. In Holly, you could see this bluish discoloration underneath the skin. That's actually her facial vein, okay? So it's creating a Tyndall effect there. Let me just turn your face towards the light. It's just there. If you can't see it, you will have to take my word for it. And also we have the facial artery that is just traveling up there and going towards the medial canthus. So they are the key vascular dangers in this area.
Perfect. Okay, wonderful. Thank you, Cam. Let's have a look a little bit more closely on the augmented reality model that we have of the infraorbital area or the periorbital area, so that we can get a real appreciation for what lies beneath the skin. This is an area that is very densely populated with all kinds of anatomical structures, and it's all of these structures that will contribute to sometimes the same appearance. So we have the tear trough itself. The tear trough is the attachment of orbicularis muscle into the orbital rim. Okay, that's a deep structure. Sometimes it's a very tight structure. Sometimes the muscle is so adherent there is no true gap, and you have to find yourself just almost creating or dissecting a small gap to be able to lift out the hollow. We know that this area above this line, we have the orbit and the orbital contents, and sometimes we have orbital fat that will herniate or push out. Sometimes the orbital septum is weak and loose, and that also can bulge out. The skin itself can also contribute to the same appearance, so with hollowing or discoloration or almost translucency. Again, that's another contributing factor. You can go on and list so many different factors involved in dark circles around the eyes. And because they are so multifactorial and they are originating from different anatomical regions, it's important to always appreciate the limits of tear trough correction. Tear trough correction is purely there to help lift out some of that tight attachment to the bone and just to give the muscle a little bit of support from beneath. That's all. If you have orbital fat herniation, can't be fixed with tear trough, don't try. If you have thin skin, again, you're not going to be able to hide any filler if you inject superficially. We can see from the model that the anatomical layers around the eye are different to the rest of the face. They are very delicate, very thin. The skin, paper thin, the thinnest skin on your body. No superficial fat, followed immediately and adherently with the orbicularis muscle. And sometimes that adherence and that tightness is so extreme that you can really feel it and see it pulling in on the skin, really kind of tethering the skin down to the orbital rim. So that's the muscle. Underneath the muscle, usually we would expect deep fat. There is no deep fat here. Then immediately we have attachment to the bone. And sometimes, again, that adherence is so very tight, there is no gap, no true gap that you could slide into. So your job is really to make sure that you are under the muscle, because there is no space or margin for error if you are above the muscle. So make sure you are under the muscle, sliding in with a blunt cannula, dissecting a small pocket under the muscle, creating some space for your filler. If you rely on the filler itself to magically expand through this area and know where it's going to go, you're going to be mistaken and you're going to be disappointed and you're going to be left with a disappointed patient, because that filler is not going to follow your expected course. That filler is very soft and it will follow the course of least resistance, which is usually outside of the muscle. It'll flip outside of the muscle or it'll slip out away and above the muscle. Both of these problems or both of these issues will create real problems for your patient. Right, Cam, back to you, and you're going to demonstrate for us a very safe and very reliable tear trough correction technique.
Okay, wonderful. So, like I mentioned earlier, we've spoken about the anatomy. The technique that I will use will be the cannula approach, and it will be the 25 gauge 50 millimeter cannula. And I will use a lateral approach, and I will need to make a new entry point with the trocar just because the positioning of the previous entry points for the deep fat pads don't quite align with where I need to go. And then P for product, okay? Which product are we using for this area? We are using Redensity 2. So this is a product that is specifically formulated for the tear trough region. Why is it specifically formulated for this region? So there are two elements to this. There's the biochemical element to it, which the supplemented phosphate buffer within which the hyaluronic acid is placed and is swimming helps to support the extracellular matrix and upregulate the fibroblast activity to help just redensify that skin. And that's why it's called Redensity 2. And then the other aspect of it is the physical and the rheological aspect of it. So we have 15 milligrams per mil of hyaluronic acid, and this is a mix of cross-linked, 5.5% cross-linked hyaluronic acid within a sea of non-cross-linked hyaluronic acid. This gives us the optimal physical qualities to respect this area. It makes it malleable and forgiving in an area, just as Ayad has explained. If you overshoot, then it will cause problems, especially because of the dynamic nature of orbicularis oculi, and with the aging process, you get fenestrations as that circular muscle just loosens, then the filler will often rise up, even if you've put it in the right plane. If you've put the wrong filler in that area or you've put too much, it's unforgiving. And then we also have the hygroscopy of Redensity 2. So the hygroscopy is its ability to attract water like a sponge. So Redensity 2 has an optimized hygroscopy for this very delicate area in that it will not absorb too much water. And the in vitro clinical studies for Redensity 2 suggested a one-to-one correction. However, we would always say to err on the side of caution and undercorrect with regards to the volume that you put in this area, because inevitably the salt load effectively of the filler will attract some water. However, Redensity 2 was made to bear that in mind. Therefore, hygroscopy, the actual physical characteristics, the malleability, and also the biochemical properties enable this to be the optimal product. What may you think is the advantage or the benefit of having free HA in amongst the cross-linked HA? Because surely to lift out a hollow, we need cross-linked HA, which is a bit more rigid. This is what protects you to a certain extent in avoiding the dreaded Tyndall effect in this area, especially in Fitzpatrick skin types 1 and 2. That free hyaluronic acid just gives you that bit of flexibility that if you have just slightly over-egged the pudding and overindulge in the product that you've put in, that it will be hopefully forgiving enough for you to massage and reduce the chances of having a Tyndall effect. Okay, so that's your A, your T, and your P. So we're ready to treat now.
Yes, we're ready to see the magic. Cam, go for it. Yep. Show us your treatment, please.
So, Redensity 2, it comes as a blue plunger, and I'm using the 50 millimeter cannula that we used previously. And again, for this area, we need to take a measurement and see how our cannula can reach the area. Anatomically, where am I putting it in space? One area I want to avoid is entering near the zygomatic cutaneous ligament because of the proximity of the facial vein to that zygomatic cutaneous ligament. We know that that will give a whopping big bruise if you go in with the trocar. And then if you do cannulate and put any product in there, we know that the vein is relatively avalvular. Therefore, the product can actually travel to the cavernous sinus, which we don't want to do. So just having a little look, not touching the cannula on the skin, having a lateral approach, and then using my favorite fingernail method, where I will just leave a slight indentation in the skin. We will just sterilize again. And I'm using the 23 gauge trocar that comes with the syringe, pinching up the tissues. We scratch. Well done. We are aiming to go onto the periosteum. Therefore, the trocar has gone in at 90 degrees. And as I mentioned earlier, I will leave it in for a few seconds to ensure that I've not directly gone into a vessel, because one would assume you will get flashback if you have. And I think that's long enough. Okay. So just popping the cannula in. There we are. And the cannula is in, but very important distinction to make. Here, we are too superficial. You can see almost the color of the cannula medially and the outline of the cannula more laterally. Therefore, I lift up the tissues and ensure that I go deeper, and now I'm gliding on periosteum, and look at the difference. Okay, hopefully you could appreciate that difference, Ayad, on the camera.
It's very clear. Yes, absolutely. I think you've demonstrated that really well. It's such an important distinction to make, because it really could be the difference between a perfect result and a perfect disaster.
That's it. So now you can see I'm pretty much near the medial canthus, but when I lift up the tip of the cannula, you can't see the color of it. And that is a distinction for me, that I'm below or within that SMAS layer, within orbicularis oculi, whereas previously when I showed you, you could literally see the color of the metal underneath the skin. So I normally like to start at the medial canthus and leave a small bolus of product. Because of its malleability and the rheology, I know I can just massage that into the medial canthus without having to take the cannula further towards a known danger zone where the facial artery and the facial vein are almost convergent. So I have put in 0.1 of a mil so far, okay? And you can see I'm being very careful and just going back and forth. And what I will do now is I will stop at that point and withdraw my cannula, and we will just reassess the whole of that tear trough region. And the wonderful thing is it will just allow you to gently manipulate the product into the areas that need it, okay? So without having to take my cannula towards the medial canthus, I can just massage it up into that area. And there we are, okay? So I will just get Holly to sit forward, and we now no longer have a tear trough deformity on that side.
What's the total
Okay.
volume of product that you've used there, Cam?
So again, no smoke or mirrors. We have nothing to hide. Just over 0.1, 0.15.
Yeah, absolutely
Okay.
perfect. Absolutely
And that was
perfect.
because we did that mid-face augmentation first. I would rather underfill than overfill. And if we just get you to turn to the side, because I feel assessing the tear trough deformity is almost best done on the profile view, and you can see there is no hollow there any longer. The Q-tip just glides gently down the cheek from the under eye area. There is no valley there left to fill. If you just tilt your chin down for us, please, this exaggerates the trough. And if you compare treated to untreated side, clearly there's a difference there. And we haven't used a lot of product.
No, it's a very visible, very effective result, Cam, in the worst angle, worst light possible. So if you can't see it from this angle, it's not there. I think that's a fantastic correction. Massive credit to you for your meticulous technique. A huge credit and thank you to your wonderful patient who's sat there listening to all these gory details about anatomy and all sorts and has been absolutely faultless throughout. So thank you, Cam. We're going to move back onto the augmented reality model for a final time, just to have a final summary of where Cam was. He was under the muscle. That's the take-home message from this. Stay under the muscle. You have the coverage of the muscle above you, and you are reaching under until you feel the resistance of that attachment of muscle starting to attach into bone. That is your indicator to stop pushing. If you go beyond that, you will go through the muscle and you will become subcutaneous too high up in the tear trough. So advance and feel for that resistance. When you feel that resistance, withdraw. And just in that vicinity, do a little bit of dissection, blunt dissection with the cannula, create a bit of space between the muscle above and the bone below. And it's that space that you're going to just help to support and lift out with some product and stop there. And you'll find that the product will disperse very gently through the area, and you're not pushing it in under pressure, so it's not going to migrate or move or affect any neighboring areas which would be detrimental to your final result. Of course, if you had that continuation of the tear trough coming more to the midline and then laterally, you have the palpebral malar groove, which is basically the separation between the orbicularis muscle and then the superficial fat in the malar area. And your job there, again, is just to enter that area, lift it out gently, and provide a little bit of support, a little bit of blending to soften that lid-cheek junction. So, in summary, we have covered in the periorbital area, we've covered basic anatomy. Of course, this is not an anatomy lecture. This is not exhaustive of the periorbital anatomy. It's a very complex topic that would need a lecture by itself. But it gives you a broad outline of the important landmarks above, medially, laterally, and of course the vascular anatomy and those important pitfalls that we can definitely avoid. And then we've talked about the product choice. Product choice is vital to have a product that is specialized and designed for this area, because it's such a specialized and very sensitive area that could really be negatively affected by overfilling, and sometimes those changes are very difficult to reverse. So product choice is absolutely vital. A Redensity 2 remains the only specifically designed product for the tear trough. And then finally, of course, Cam demonstrated a very safe, meticulous technique with a tiny volume of filler that absolutely corrected the problem from the deep to the superficial to create a very beautiful and very natural correction of midface and tear trough. So that concludes our session tonight. In terms of the clinical aspect, we have some time for questions. My ear is absolutely burning with questions from backstage, so we're going to proceed. Cam, are you still with me, or have you run away? He's run away. Amazing. So the first question is, could you use one entry point to cover both deep and superficial? I'm going to start with this one, if it's okay with you, Cam. It's actually my preferred technique to use a single entry point. I generally take an entry point in the lateral orbital line, immediately under the malar fat. So we can identify the malar fat here, and immediately under that fat, we go in. It's a very short distance to the bone. We can hit the bone very quickly and very easily. And by doing that, I suppose we're crossing minimum anatomy. We've got less risk of injuring structures along the way. So at that point there, I make my entry point for the cannula, and from that point, I can access submuscular into the medial SUF, come back to the entry point, up to the lateral SUF, come back to my entry point, down obliquely to the deep medial cheek fat. These are all deep injections with ultra deep. Stop there. From the same entry point, we can use RHA4 or RHA3 in thinner patients, and we can go superficially to treat all of the medial, middle, and lateral cheek fat, avoiding the malar fat and the nasolabial fat. So that's my preferred technique, and everyone will have a different variation of these techniques. There is no right technique and wrong technique. It's whatever works best in your hands. And everyone who's watching now will take small tips from Cam, small tips from myself, and they will apply them to their own practice and make it their own technique. Cam, do you have anything to add to that?
No, I think that was a comprehensive answer. My preferred technique has been seen today. You know, I feel sometimes the straightest way to go from A to B is in a straight line, and hence I like to use a needle on the periosteum. But you do need a firm grounding in the anatomy to be relatively safe when doing that. But otherwise, you can use the single entry approach.
Fantastic. Cam, I'm going to ask you a question that's come up on my screen. How would you change your approach in a male patient?
Okay, a good question. The main thing when comparing the male midface to the female midface is you have more abrupt transition zones. The light and shadow changes quite abruptly, whereas in a feminine face, there's a gradual transition. And in a male face, it's more linear, okay, compared to the feminine face, which has got much more curves in it, and it's more curvy, linear. And then possibly the most important feature is the ratio of volume of the anterior cheek to the lateral cheek in a male is effectively 1:1, whereas in a female, it would be 2:1 anteriorly to laterally. So if you were to do that on a male, you would feminize the male face by creating that apple cheek. And therefore, that must be respected. And they're the key features for me.
But of course, that's exactly right. There are different aesthetic ideals that we perhaps try to reach for more feminine faces, for more masculine faces, for wider, thinner, whatever. But the anatomy remains the same. The structure under the skin remain the same. The fat pads are still in the same planes, and that organization of the layers is still the same. And so we can still apply the same treatment approach to all patients. And that's what I was saying about the universality of this kind of technique and the very predictable results that can be achieved. Now, if you wanted less lateral cheek projection, we'll go easy on the lateral SUF, okay? If you want more lateral cheek projection for a higher cheekbone and more feminized features, then you can go into the lateral SUF or the pre-zygomatic area to really create very pronounced results. But always, we are aiming our treatments anatomically and not randomly or by some template or measurements. Okay, so that's really important. So you can take your whatever ideals you want to achieve, but make sure you deliver your treatment anatomically.
I think just adding to that, you can't just treat an area of the face in isolation. For a male face, often looking at the bigonial distance in relation to the bizygomatic distance is also so important. So I think both Ayad and I would say, don't just look at an area in isolation, look at the areas above and below.
Perfect. Thank you, Cam. Now, a common question, a common concern for a lot of patients and practitioners is that dreaded malar fat and the malar edema. Cam, what's your approach for avoiding and possibly even treating this area?
I think avoidance is key. I think there needs to be a clear differentiation between the malar fat or malar mound, which is usually, it's a genetic predisposition to having a collection of fat there. There are some famous actors, Al Pacino for one, who has had that since his younger days. I think sometimes when the surrounding fat and bone atrophy, it can look more pronounced, but it's usually always been there and it's a part of them. Malar edema is usually an impact on the lymphatic drainage around the area, which causes lymphatic stasis and a puffiness and a bogginess to the area. And sometimes incorrectly placed filler can do that, or if you use the wrong filler in that area, which if you're using a highly cross-linked filler that then impacts the lymphatic drainage, and also a highly hygroscopic filler, which also draws water in, it can often create malar edema and create that bogginess and puffiness in that area. But if they have a pronounced malar fat pad, the best thing is to inject around it and avoid it at all costs.
Perfect. I think it's the malar fat, the malar area is an absolute pig when it comes to aesthetic treatments. It's an area of appalling lymphatic drainage. It's bounded inferiorly by a ligament, superiorly by a ligament, and so the only lymphatic drainage it has is lateral. And so that's really inefficient and inadequate drainage in many people. So the really important thing, exactly like Dr. Khan was saying, is to avoid adding to that problem. And by adding to that problem, what might add to that problem is by adding, well, filler, product, volume, water to that area, and really almost overwhelming that lymphatic capacity of the area. But also what's really important is trauma. Trauma can worsen the lymphatic drainage because it can directly injure and scar the very delicate lymphatic channels in that region of the face. But also it can aggravate a lot of inflammation, which again can overwhelm the lymphatic drainage. So for all intents and purposes, the malar area is basically out of bounds for injections, either injecting through it or injecting into it. Just stay away from it altogether. Treatment for malar fat or malar edema is tricky. It really is very tricky because, well, by the very definition of treating, you are potentially traumatizing the area, and it may come back with a vengeance. So the best thing, again, just like Dr. Cam said, avoid it altogether. And we're going to take one final question, Cam. We know a lot about, or we're learning a lot about filler longevity in the face. How do you approach this when it comes to the RHA or the Ultra Deep? How long do you say that these products are going to last?
Okay, so not the easiest question to finish off the night on, Professor Ayad. But essentially, we have two answers here. We have the answer of what it says on the box, effectively, and the expected longevity. So for Ultra Deep, there have been clinical studies that show it can last for approximately 20 months, and RHA4, I believe, is 22 months. However, more and more evidence is coming out now that cross-linked fillers are actually lasting many years, many times longer than this. And I think that's an area that we will find more and more about with the interest in imaging and looking at how fillers evolve and change over the years using a combination of ultrasound, MRI, and obviously, our plastic surgery colleagues like yourself are finding that when it does come to the time of surgery, there are often these almost flotillas of filler from overfilled faces and these fat pads that, when they actually squeeze them, are squeezing out hyaluronic acid, highly cross-linked hyaluronic acid filler. So there's no simple answer to this, but I think more light will be shed in the sort of months to years to come as we have an actual look into this with imaging technology.
Perfect, perfect answer. Thank you, Cam. I would add that fillers absolutely can last years, much longer than we expect. And it's really important that we don't overwhelm the face with fillers. What does happen with time is not so much that the filler deflates and you reach that 12-month threshold and the filler will disappear. That's not going to happen. It's not going to happen. But what does happen with time is that the face changes. The face continues to change. Those aging processes are ongoing. So it's not just a matter of how long will the filler last. Well, actually, you do it when there is sufficient change in the face to warrant adding filler. That's a very, very long-winded answer for your patient who's going to want a number, but that's the right answer to give them. So what I normally say to my patients is it will last long-term. Probably your face will change over the first year or two, and in a year or two, we can revisit this area, we can top up as needed, but what's for sure is that we're not replacing the filler, we're adding onto it every time that we do these treatments. So be careful how much and where you add.
Yeah, I think that latter point, very, very important, is even more important that you make sure that the placement is correct. So you're using the right type of filler in the right plane, basically.
Okay, wonderful. Dr. Cam, Professor Cam, it's been a pleasure, always.
Always.
I'm very jealous that you got to go to Birmingham and I had to stay here in Paris. But perhaps next time it'll be an opportunity for me to share the delights. Thank you to your wonderful model and patient for her patience.
Thank you, Holly.
And thank you to everyone who's joined us tonight for this very new, innovative type of webinar. I hope you've enjoyed it. We'd welcome your feedback, and if you have any follow-up questions or comments, they are always welcome. If you just follow up with the Teoxane Pro account and drop your feedback there. And we look forward to seeing you at the next webinar very soon.
Bye-bye.